radiology, and she's an expert in virtual autopsy, which is a technique that has been widely used during the COVID to make the autopsy. And I am glad to have her here. She has been also graduated in the second level master course a couple of editions ago. So Laura, thank you for coming. I leave you the floor.
Thank you for the nice introduction, Professor Malizia. I'm Laura Filograna. I'm a radiologist and forensic pathologist. It's for me a pleasure to introduce to you this subject, forensic radiology and virtual autopsy, and to give you an overview of this particular object of investigation in forensic field. Please feel free to simply stop me if you have questions during my presentation. Yeah. Forensic radiology, the definition is quite simple. Forensic radiology is a branch of radiology that focuses on detecting imaging findings important for medical legal reasons in livings and cadavers. Does someone of you know what virtual autopsy is or virtopsy is? Well, virtual autopsy or virtopsy is a technique of forensic investigation that is the main object of my presentation, and it has gained ground in the last 30 years in forensic investigations. It applies the modern imaging techniques also used in clinical environments, in clinical field, first of all CT, but also MRI and other imaging techniques to investigate the cadaver for a minimally or not invasive technique as a complementary or even in selected cases substitutive tool to traditional autopsy and invasive autopsy. This is the index of my presentation. I will start with a brief history and of virtual autopsy and the techniques applied. That are PMCT, postmortem MRI, and so on. We will see later. And finally, I hope to have the time, I will go quickly, to reach the case series where was postmortem CT was applied in a virtual autopsy concept in 9 victims of a terrorist attack in Dhaka that I studied with my collaborators. Forensic radiology started 1 year later the discovery of X-rays by Röntgen. In 1996, the first documentation of projectiles in livings and cadavers. The evidence in suspected malpractice or images of the foots were used to estimate bone age and so on. So X-rays were almost employed to forensic investigations in the first years, year after discovery. In 1977, 5 years after the creation of CT, that is the main technique, the basic technique for a virtual autopsy, CT was applied by Wullenberger, Schneider, and Rummer for studying gunshot wound to the head. And this is one of the main topics of virtual autopsy. And in 1983, some other studied this particular field of investigation. But the real step forward was done when Calender and Fock, the chef, the boss of the Institute of Radiology in Bern, when I was there to study virtual autopsy, invented spiral CT, multi-slice CT, because it prompted the translation by 2D imaging, X-rays as is 2D, two-dimensional imaging, to 3D imaging. And this advantage was suddenly captured by forensic investigator, and with the flourish of works and publications. MRI was invented, we can say, in 1973, but it was introduced in the clinical investigations early in the 80s. But Ross et al. In 1990 performed the first study by comparing post-mortem MRI imaging as with autopsy, but they intend to use post-mortem MRI as a pre-autopsy technique with good results. But why do we have the birth of virtual autopsy? First of all, the decreasing acceptance of traditional autopsy is one of the main causes. The need for verification of clinical diagnosis, and also in forensic medicine, the diagnosis in clinical and forensics are of huge importance for epidemiological and justice reasons. And on the other hand, we have traditional autopsy that is invasive and destructive, not repeatable. It means also loosening of data, and it has an information to the histological, morphological analysis. It's always two-dimensional, and the need for objective data and telemedicine. In the mid-80s, the professor Dirnofer, the director of the Forensic Institute of Bern, started a project with the police of Zurich with the aim to document in 3D the surface of the objects and the bodies. This is the beginning of the virtopsy concept. And a few years later, in the mid-90s, Professor Tali, my boss, created virtopsy by the idea, from the idea to document in a minimally invasive way the inside of the body with the CT and MRI, and to compare these findings retrieved with the forensic relevance with traditional autopsy results. What is virtopsy? Virtopsy, the term origins from the fusion of virtual and autopsy. Virtual, from Latin, means useful. Autopsy comes from the ancient Greek and is from autos, self, and opsomai, to see with one's eyes. So the term autopsy means to see with one's own eyes. Because the goal of virtopsy is to eliminate the subjectivity of autopsy, the term autos was cancelled, And the two terms, virtual and autopsy, opsomai mixed, merged in virtopsy. These are the main techniques applied in virtual autopsy. CT is at the center because it's the main technique. We will see why. CT-guided biopsy, MRI, angio MRI, surface scanning, and angio CT. Virtual autopsy is basically a CT scan of the whole body of a cadaver, generally before autopsy. The advantages are it is a not invasive techniques against the classical autopsy. It is fast. It allows data storage and archiving. Offers an objective documentation that there's an exhibition pros in think about the bloody images of an autopsy, and these images are better tolerated by students or judicial persons. PMCT is the most applied technique in violent deaths because of its diffusion on the territory. It is fast, roughly 15 seconds to acquire the entire whole body. It offers a huge, a perfect representation of the skeleton, the entire skeleton, so fractures and so on. It allows the identification of major parenchymal damage and of foreign bodies. Think about projectiles, bullets. These are the indications of a postmortem CT virtual autopsy. I will go through some of these that are useful to introduce the case series at the end of my presentation. Let's start from PMCT. The identification is perfect with PMCT. The definition of cause of manner and mechanism of death, documentation of the injury pattern, demonstration of vital reaction. A vital reaction is that findings that allows to us to say, okay, the victim was alive when that injury was originated. Personal identification is of huge importance for judicial reasons, but also for the relatives of a cadaver. And it is basically based on the concept that antemortem and on the comparison between an antemortem and postmortem imaging in this case, on the assumption that every individual is unique. Identification purposes, PMCT is really powerful in this because it identifies very well foreign bodies. Foreign bodies can be also dental implants. And let's see how it is easy to isolate these implants with CT in a complete maxillofacial destruction case. And then we can acquire with PMCT also a dental scan and panoramics reconstructions that can be compared with orthopanoramics acquired in when he was still alive, the subject. Other foreign bodies for identification can be considered orthopedic implants. Let's go to the type of injuries. I will speak you about these because we will find this type of injuries in the case series we will analyze. Let's start from gunshot injuries. The objectives also in classical autopsy, in classical forensic investigations in cases with gunshot injuries. The main issues are differentiation of entry versus exit wound, description of the intrasomatic trajectory, and the dynamics, the reconstruction of dynamic of injury event. How can we differentiate entrance and exit wound by PMCT? By the study of cranial bone defect. We consider that when a projectile enter the skull, it originates a bone defect that is conical in shape, and the beveling is directed to the exit wound. So this is an entrance wound, the conical shape, you can see, entrance wound, and this is exit wound. By the study of the cranial fractures. This is the Puppe theorem. This is an exit hole. You can see that from these originate short fractures because they stop from the fractures originated on the opposite side in the entrance wound. So the fractures originated from the exit wound are shorter than that from the entrance wound. The trajectory can be identified in imaging by the analysis of the particular distribution of the fragments of projectile or bone within the encephalon, and these have a special distribution, always with a conical shape. And by the study of gas bubbles, hemorrhage, and other lesions to the soft tissues. And the study of trajectory is particularly important when we have PMCT imaging because, as I said, we have a three-dimensional imaging. So we can have cases where the trajectory in the skull is different by the trajectory in the neck. And so I can hypothesize that the victim had the head tilted on the left and downwards to combine in a linear way the two trajectories. And this is possible just with CT imaging that in situ allows you to identify the angles of each one of the two trajectories. PMCT allows the perfect localization of projectiles in regions that are not generally dissected during autopsy. So it is a pre-autopsy techniques that allows the retrieval of important objects like a projectile for ballistic analysis and so on. blunt injuries. CT is perfect in the depiction, identification, and the study of each fracture in the body. In this case of homicide, it was used a baseball bat, and you can, with CT, see perfectly the lines of fractures and differentiate an object, a blunt object that is with a restricted surface against a wall, for example, or the ground, for example. And you can also study the fractures like Puppet theorem and say, okay, this fracture probably originated, this focus of fracture originated before a second focus of fractures because it has fracture lines longer than the other. This is a suicide by precipitation. You can see that these fractures are different from the other I presented before of a baseball bat and other fractures in the whole skeleton. Sharp injuries. CT is not so specific and useful in detecting the fine soft tissue injuries. However, in these cases where incisions were originated in the bones, you can recognize them and study also with CT, postmortem CT the case. This is the trajectory of the blade. This is an homicide by 13 cuts by the flatmate of the victims. You can study also the trajectory by analyzing soft tissue injuries. You can recognize here also a fragment of the blade, and this is important for the investigation. A PMCT is magistral in identification of bone and hair. So you can see pneumothorax, but also gas embolism. This is a finding also in the all the vessels, intracranial vessels, and this is incompatible with life. So this is also a cause of death that was missed before the era of postmortem CT, because during autopsy it is impossible to detect this, and it's quite difficult to detect air in the heart cavity. This is the heart. Because you have to cut the pericardium to fill the pericardial space with water, and then with a knife puncture and let the air come from the inside of the heart cavities, and let's see if you can see some bubbles. You are lucky. And also you can quantify this finding. Explosion injuries. Explosion injuries can be well defined by a mix of blunt hit and gunshot, because the explosive material is like projectiles. And you can see here some lesions, so you can find similarly to gunshot, blunt and hit injuries we will see in the cases after. Postmortem MRI. Postmortem MRI is not so usually employed in virtual autopsy. First of all, because it takes more time to perform a postmortem MRI than a CT. Then the diffusion on the territory is lesser than CT, and it costs so much. So generally it is used for the investigation of particular organs, specific organs, probably never for whole body imaging. For example, it was used for soft tissues. We have said CT is perfect for skeleton and not so good for soft tissue. Postmortem MRI is perfect for characterize soft tissues injuries. You can see here, this is a CT image. Here, the same image in MRI. You can see the hemorrhage perfectly extrafascial, intrafascial, etc. And also you have not a chance in postmortem CT to identify this hemorrhage in sternocleidomastoideum muscle. And you can see here this finding very well. This is a CT image where you can detect these fractures of hyoid horns and the perfect correspondence in autopsy. And then you can see a gunshot wound, a projectile trajectory along the cerebellum. You can see you see how it is bloody in comparison to this image. And also specific organ. One of these is the heart. You can see a subacute myocardial infarction on a basis of a chronic infarction that causes the death of the subject. And in a case of drowning, you can see fluids in maxillary sinuses. These are maxillary sinuses and in duodenum that are signs of vital reaction. So the subject was not submerged after that, but it breathes during before that. And post-mortem MR spectroscopy is particular technique of MRI. It was used to study brain metabolites over times so that time since death could be identified. Or it was used to study illegal heroin spectrum in the vitreous humor, so for toxicological aims. But what are the limitations of PMCT? It is not so good in the depiction of the origin of hemorrhage. You can see that there is an hemorrhage, but the vessels without contrast media are not well are not enhanced, and so you cannot recognize the injury of the vessel or the origin of the hemorrhage, for example. And CT offers an information that is macro, the macro morphology of the injuries. So the important part offered by autopsy, that is histology and toxicology, is impossible with postmortem CT. To overcome these limitations, other techniques were implemented in virtopsy. These are two cases where postmortem CT failed in gathering informations in these two cases. So this is a case of multiple abdominal, thorax, abdominal, etc., gunshot wounds with the intersecting trajectory, so you have no chance to depict with confidentially the single trajectory. And this is, okay. This was a case of a woman death by myocardial infarction, and the CT, postmortem CT, is completely silent for any finding indicative of death by heart infarction. So what was introduced post-mortem CT angiography in 2005 by Jankowski et al., the group of Professor Tali, my group, and that since that time many techniques were used. Different by anatomical district or total body or selective angiography were performed. The type of contrast media, water soluble and fat soluble. Propulsion method was or manual or automated with heart-lung pump for extracorporeal circulation. So after incannulation of femoral vein and artery, the contrast media is pushed in the body for circulation by this pump. And acquisition phases, basal, arterial, venous, some groups also a dynamic during the contrast media injection with that pump. These are some examples. This was an accidental death. You can see this is the cranium, the compressive craniotomy to release the rise of intracranial pressure. You can see subdural hemorrhage, subarachnoid hemorrhage, intraventricular hemorrhage, and here in arteriospace, like it occurs in the livings, a complete absence of opacization of the medial cerebral artery. This is a case of aortic dissection, the type A, Stanford A, where probably the dissection opened in the pericardium and causing a heart tamponade and the death of the subject. You can see here the blood in the pericardial space. Here you can see a selective angiography, postmortem CT angiography. You can see a coronary aneurysm and a stenosis, coronary stenosis. And also pulmonary thromboembolism. You can recognize this thrombus, central thrombus, and also the thrombus in the inferior cava vein. But we need always a confirmation of this thrombus because there are also postmortem coagules, and the differentiation can be done at the moment with histology of the thrombus or coagules, and the histology confirmed that it was really a pulmonary embolism. Here, a gunshot wound victim. You can see perfectly the trajectory in the liver. It is an accidental case. You can see the lesion and the hemorrhage hematoma of the kidney, of the spleen. But what about histology and toxicology or microbiology, macrobiological analysis? The group of Tali in 2007 was a pioneer in this field because they demonstrated that it was possible to acquire with post-mortem percutaneous CT-guided or not guided biopsies, so with the needle through the surface of the body without opening the body, so in a minimally invasive way, samples useful for histology, histopathology, for toxicology, microbiology, and so on. For example, an acute myocardial infarction was demonstrated with this technique. A myocarditis, a lung cancer. You can see the sample with the true cut. And fat embolism. Fat embolism is a vital sign. It originates when a fracture of long bones occurs, because when a fracture occurs, the lobule of fat inside the bone gain the circulation through the lesion of the vessels, and they go in circulation and come in the lungs. So this is a specimen from the lung, from the right lung, and you can see with this coloration that is Sudan free. You can see a huge, grade 3 of fat embolism that is also a cause of death, but it is a vital reaction. It means that the subject was alive when the fracture originated. So let's go the last 10 minutes to the case samples. This was a study for me and other collaborators from the University of Catholic University of Rome, where I studied. In Dhaka, in Bangladesh, a religious group raided a restaurant and using pipe bombs, sharp edge weapons, and various types of firearms, handguns, machine, etc., or explosives, they killed foreign customers and tourists. 9 tourists were Italian, 5 females and 4 males. 1 female was pregnant, and the local forensic pathologists performed, as always occurs in these cases, performed a first autopsy in Dhaka. Then the bodies were translated to Rome, to the Institute of Forensic Medicine of Catholic University. They underwent an external examination and then a whole body PMCT, and then a second autopsy. Almost the cases had gunshot wounds, just 3, 1, and 6 didn't have gunshot wounds. 6 on 9 cases had stab wounds, and 3 on 9 cases had wounds related to IED, improvised explosive devices. It starts from the victims of stab wounds. 4 on 6 had slash wounds, so the injuries were from cut, but also blunt injuries, because slash are also can also cause blunt injuries, and free cut superficial wounds. You can see in these images how the bone is damaged by the blade. These these signs of the blade on the skull, and slash wounds created also fractures. And you can see here also a projectile that was not retrieved in the first autopsy. So PMCT was a guide for our second autopsy for retrieval of this projectile. And to retrieve a projectile is important for judicial reasons, for identifying the terrorist group. So in cases of sharp wounds, post-mortem CT allowed the description and 3D visualization of fractures. We have seen how it is important, and parenchymal injuries, and identification of fragments of the blade. This is a fragment of the blade. This is a projectile, but this is a fragment of the blade. In gunshot wounds, in this is an entrance wound. You can see the beveling, as I explained, entrance wound with the beveling. And then you can see here in the facial region. So let's think about the relatives of these persons. In Italy, during autopsy, you can perform some specific cuts. All the cuts in the face or particular regions that are not the formalized, the regular cuts of an autopsy are a cadaver violation. So it is judicially important not to cut if you have not a reason and the approval of the justice. So you can see here this projectile, and it could be also here. Here is in the neck, the soft tissues of the neck. It was retrieved during the autopsy. So the advantages were the description and 3D visualization on bone and soft tissue injuries, identification of entrance and entry and exit wound and of the bullet track, localization of foreign bodies. This is important for reconstruction of mechanism and dynamics of death, determination of the cause of death, and to give information about for national and international counterterrorism agencies. 3 subjects had wounds related to caused by IED. And you can see and study in these images the source of the explosion, the position, relative position, you can hypothesize, of the victim, and also like it occurs with gunshot wounds, you can make inferences, hypotheses on the distance of the explosion. Of course, in disaster victims like these, post-mortem CT it was not the case. We know the identity of each victim, but post-mortem CT has great importance in identification of the victims. So I think it is clear that is always also when the first autopsy was performed before, and we have to perform a second autopsy. Post-mortem CT is really useful for analyzing forensically these kind of cases, particular cases. So, do you have questions? We have 5 minutes. Doubts? No? Okay. Thank you. Thank you.
So we have 10-minute break and then we start with the last batch, okay?
Bye bye.
Bye bye. Thank you. Insomma, io penso che ci prende spazio per non sei tutto per finora. Quasi per me era un forse minchia, quello mi fa paura. Non eravate, non c'è dentro. Però c'è un problema in mezzo. No. Stavo riflettendo. E poi c'è insertato. Meglio così. Così si può giù quello tu. Ah, sì, no, però non è guidato, poi andavi a vedere, non lo stesso. Vabbè. Andiamo insieme.
Colori, sto in aula, ci stai?
Sì.
Non dovresti fare una cortesia. Quando parte Gabriele?
Sì?
Dovresti sentire nell'ordine Alessia ed Alba. Alessia ti dovrebbe dare i nomi di chi gli hanno detto che hanno pagato per Cisint. E
Sì?
con Alba dovresti fare una verifica di controcheck sul conto corrente ESAR.
Se ce ne sono altri oltre a quelli che ci ha dato stamattina.
Se ce ne sono altri oltre i 6 di stamattina e se i 6 di stamattina o quelli che ci sono, se se ne è aggiunto qualcuno, corrispondono con quelli che Alessia hanno detto che l'hanno fatto.
Ok,
Ok? Vedo lo schermo. No? Laura, com'è andata?
bene, molto
Ok.
bene.
Beh, bravo.
انا شو اسوي؟ شو اللي اجيت انا؟ والله اجيت بس سويته
Non perché questo però è l'approccio classico del fisico. Cioè, dice una cosa che sembra simpatica, gli fai una volta l'anno, e allora qua si autoconvince che è simpatica e la ripete come un verso simpatico, forse è l'unica volta l'anno che è qualcosa che pensa che sia simpatico. Quindi devi essere comprensivo.
È stato Caruso, però poi gli ho detto, se andare a Bologna, perché sì. No, per sapere se gli anni ti fanno di rosa, ti passa sempre.
Allora ti dico che voi che hanno un progetto stanno lì, ma Samuele ha fatto un salto tutto il giorno, già molto stanco.
No, no, guarda, non ti non è neanche male.
Anche cambiare un po' più spesso docente aiuta a tenere l'attenzione un pochino più. Sì.
La droga aiuta, no?
Guarda, ho sentito lei quando faceva lezione, bravo Brando Martello. Diciamo che è un approccio poco accademico e più. No, ma io l'ho visto stamattina che era dura la cosa quando me ne sono andato, lei quando ha cominciato a parlare ha attivato il timer. Lì ho capito che sarebbe stato lo stesso. E quando un docente mette il timer su cazzo. Perché fa il martello, deve fare 4 blocchi da 45 minuti a stecca deve finire tutto.
Giri di sopra, a sforare.
Di solito andiamo a braccio, però poi dimentichiamo di quella cosa lì, ma sta.
Per forza sarebbe nuovo di niente, perché faccio 3
Poi mi chiede da quando è previsto il passo un'informazione sulla attività, perché il passo è programmato mezz'ora dopo la fine dell'attività, non so a che ora hanno programmato la fine dell'attività. Però ma come stai il gruppo di imprese si metti dentro Colomba così, è un'informazione che secondo me è utile per tutti quanti. Ciao professore. Devo prendere all'acqua.
La fonte, la
famosissima acqua di Giuga.
Giuga è il dottore.
Quale delle due? Te l'ho messo tu, eh?
Forense patologia in credit.
Vai, apri.
C'è sta pure.
Come no? Colò, ci sei?
Sì,
Il professore è quasi pronto.
Pensate. Allora, vediamo come funziona un po'. Va? Devo mettere presentazione, no?
Sotto, vicino allo zoom. Quella, bravo. Proviamo? Ok.
Quindi, com'è?
Avanti, indietro, in mezzo e
Il puntatore.
pure tu parla sempre nei dintorni
Nei
del
dintorni.
computer, così ti prende la voce.
Ok. Aspettiamo i nostri compari. Ah.
Guys, come on, ready for the last 3 hours? You look me very bad. It's 45 minutes, don't worry. Quello ci sei? Stai registrando?
Sì, aspetto
Sì.
che forse c'erano ancora alcuni.
No, e cominciamo.
Sì.
Quando entrano. So, good evening again for the last time today. I will introduce the lecturer. You already know him because he spent some time with you during last week. He is Dr. Gabriele Giuga. He is forensic pathology and legal medicine specialist here at the University of Rome Tor Vergata, and since February 2025, he is also research fellow in CBRN activity here at the University of Rome Tor Vergata. So he's also all the stuff that you can read on the first slide is very important. And the nice thing, I think, is to see how his work is important in a CBRN point of view, so in CBRN key. And this is what Gabriele want to explain with the lecture today. So Gabriele, thank you for accepting the invitation for the lecture. I'll leave you the floor.
Thank you very much. Professor Malizia. Here we are. The lesson will last about 2 hours, so...
Gabriele.
Yes, including, you know, I try to go faster so you can go away, you can relax. It was a tiring day, so I hope to make an interesting and interactive lesson. So just to avoid the noise. First of all, I want to ask you a question for you. Why, according to you, in 2020, many countries banned autopsy on COVID positive patients? And according to you, what do you think about it? It was a careful choice or was a scientific error? Just tell me your point of view. Feel free, it's just an interactive lesson. I just want to know your point of view.
At the moment, it was, I think, a careful choice because it was a pandemic, so we didn't know what could be the effects of to open the corpse, and maybe we could have a new biological expiration. Huh?
Okay.
So I think at the moment in 2020, I think it was a careful choice. By a scientific point of view, maybe not. But after some years that we did this choice.
Any other points of view? Maybe from the friends from the west, from the east, from the east, the far east. What do you think about?
I would say maybe because of the the autopsies affect the cells, so it will be weaker immune system, maybe.
Okay. Any other opinions? Different from this? Okay. I think I agree with you, in part agree with you, but it's important to underline that during a pandemic, the autopsy has a value, an intrinsic value, because as you can see, there are scientific value, epidemiological value, and a forensic legal value. I agree that in the first moment we were scared because we didn't know what we had ahead of us, and it was a new pathogen. It was something unknown. You know, when there is something unknown, we are scared from it. But we have to underline that we don't have to be scared from what we don't know, because often when we don't know anything, it's inside of that the truth, and it's inside of that the progress. As you can see, the scientific value, because autopsy lets us understand why any mechanism, some mechanism of disease, like pulmonary thrombi, and I will go deeper in the argument. But even the treatment protocols, public health, because maybe if we have done the autopsy before, the number of deaths would be few, really few, because with autopsy, we understood the mechanism of the virus, we understood how to face it, even the treatment. Because, for example, I underlined organotropism, the pulmonary microthrombi, if we understood this before, we could face it with the appropriate therapy. And that was what we lacked in the first phase, okay? Even from epidemiological value, because we literally didn't know why the people were dying, because we just knew that it was a death with COVID or from COVID. That's a big problem. We didn't understand the manner of that, the cause of that. We just were going by touching the ground, in a blind way, you know. And even for the forensic legal value, which is my job, because when we work with the prosecutor office, when we have to work for the judge with the court, they usually ask us 3 questions: the time of death, the manner of death, and the cause of death. Even excluding medical ability. Imagine your parent, imagine your father, your mother in a hospital suffering with COVID or from COVID, and you don't know, because if the death occurs, you didn't know if maybe it could be a medical liability, maybe a medical error. You didn't know. If you don't perform the autopsy, you could not understand the real cause of death. And this was a crucial problem during the pandemic. As you can see, I made you a collection why, during the historical samples, why in pandemic, during the Spanish flu, for example, this was the Spanish flu, really very few autopsies were performed. So we literally didn't know why the people was dying, because there was the same panic that should be, the same feeling of don't know, of be scared from what we didn't know. The important thing is HIV, really with autopsies during the 1980 period, we could understand that the HIV was related to an important immunodepression. And the most frequent cause of death was not the HIV, but the cytomegalovirus and Kaposi sarcoma, which were the common complications of the HIV, which are the pathogens which can occur after an immunodepression. But only with autopsy we could understand this, and we could improve the therapies. We could save people from or at least contain the pathogen. The same for COVID-19, because as you can see, I just insert just this information. I will explain better, because the colleague before me came here and explained the virtual autopsy, you know, the teacher from the lesson before. Because there are different approach to the autopsy. We, as a legal medicine, make a full autopsy, which is a complete examination. But the pandemic taught us other approaches, like, for example, the minimal invasive autopsy or the virtual autopsy. But there is a real difference between them, because as you can see, lower is the safety level, but even the diagnostic power is higher. So with a virtual autopsy, with a minimal invasive autopsy, we couldn't understand, for example, what I told you about the HIV, what I told you about the Spanish flu. Only with autopsy, with an invasive approach, we can investigate the body by opening the body from a macroscopic point of view, but more important, from a microscopic point of view. Because don't forget that during an autopsy, we just make even microscopic samples from the organs, which we can observe with microscope. And that is, for example, the big challenge with the COVID. The COVID-19, as you can see, was a really hard problem for us, because do you remember from the Ministry of Health bulletin, the first phase of time, the first phase of the pandemic, they denied us the autopsy. The autopsy were denied because they didn't understand what we were facing off, what we are facing for. They were scared from the possibility, as our student told us, from the possibility to a big spreading. So we literally were stopped from performing autopsy, and was literally a stopping progress of knowledge of this pathogen. As you can see, in the March of 2020, there were the WHO guidelines from the WHO organization, World Health Organization, which recommended to perform autopsy in adequately ventilated room. For example, they tried to understand that we couldn't understand what we were facing. If we don't perform autopsy, we couldn't improve our science. It was necessary for the science to go deeper in a obviously careful way, quindi with ventilation, 160 liters per patient, the floor, with the room with negative pressure. And for example, to allow this from a legislative point of view, they inserted the COVID like a risk group free pathogen. Okay, and this was just a legal observation in order to treat adequately and properly the pathogen with, for example, the biosafety level. You can't organize a biosafety level if you don't identify the pathogen in a risk group. For example, as you can see, the BLS-free is what we were waiting for. What we were waiting for during the pandemic. For example, in Tor Vergata, we could not perform the autopsies during the COVID pandemic, because Tor Vergata doesn't have a BLS-free. In Rome, the only one BLS-free is in Gemelli, Policlinico Gemelli, Cattolica. I don't know if you know the university. They had the BLS-free and they could perform the autopsy. Quindi, for example, if I was in intern, because when I work from the prosecutor office, I'm free. For example, in the 24 hours, whatever occurs, they call me. During that period, if a dead body was found positive with a swab positive in COVID, directly sent to Gemelli. They didn't call us. Just called the Gemelli, because only there they could perform the autopsy. This is the flowchart, the timeline, because fortunately they understood this mistake, this lack of knowledge. They understood that we needed to improve the science. We needed to improve our knowledge about it. So, as you can see, from July to March and from May 2020, there was a new circular from the Ministry of Health that allows autopsy with safety protocols. So we could finally perform autopsies with safety protocols, with the BLS-free, which I told you before, and with standardized procedures. In the first time, there was the spreading of the minimal invasive autopsy, which was this. This was the minimal invasive autopsy, which was a sort of bridge between the autopsy, the normal autopsy, and the virtual autopsy, because you took the body through the CT or MT or MRI scan, and you perform an histology and dry needle MRI guided, I don't know, drawing. And so you could see with microscopy what you were looking for. Obviously, this has a problem, because the diagnostic power is moderate. You have to find it with a scanner. It wasn't so easily to identify the right points where to intervene, the right, for example, physiopathological behavior of the pathogen. So this was the first protective equipment. As you can see, maybe I think you work in biosafety levels. I don't know if some of you works with this dispositive. I think yes, maybe our this friends. And there was required a personal equipment with FFP3 mask, face shield, just because from the aerosol. During the autopsy, maybe to access to the head, you need a craniotomy. The craniotomy process, while cutting the bone, there is a huge spreading of aerosol. So you have to avoid the spreading of aerosol, which could be lethal and infect the personnel. That's why we had the mask. We had the mask with the face shield and the ground. As you can see, this is where the personal protective equipments required at least to perform an autopsy, but finally we could perform it. It was just a progress from our point of view. As you can see, there were any autopsy room environmental requirements, like negative pressure ventilation, just to prevent aerosol escape, what I was telling you before. The air exchange per hour, just to avoid this spreading, and the HEPA filters for the treatment of air, and obviously different zones where to place the bodies, because you have to understand that during that period there were lots of deaths, lots of bodies. It was a logistic problem, really logistic problem, because we had to separate the zones, the functional areas, because to avoid the spreading of virus. We didn't understand what we were facing for. So we needed to a quiet approach, just to understand each other and go deeper to this pathogen. These were the disinfection. I just want to go faster in this way because I know you are tired, and I think you will find more interesting the following part. And you have a corp. This is an autopsy room. There were the cleaning procedure. They were in mask. You perform an autopsy. Then you have to remove the corpse with the disinfection. And the procedure with the dressing room, always in separate rooms, always to avoid the contact with this liquid, with this aerosol, and so on. Finally, with this opening to the autopsies, the first studies, the first evidence appeared. Finally, we have the first studies, even Italian studies, because Italy was one of the first, one of the first country which was affected from the virus. So we were really the first. We had no measures to face it, because we were the first. There were no protocols, and we had to build the protocols. How can you build the protocols? You can build the protocols only without the literature, without science, with the experiments. And these experiments fortunately suggest us that with the protective measures in place, with the personal protective equipment, the well-ventilated environments, and disinfection protocols, the risk of SARS-CoV-2 transmission during autopsy was very low. So finally, we get, even the literature helped us. It was safe. We could perform autopsy. So we needed to improve this, to understand and to increase, to have better therapies, because during that period, the hospitals were full. The patients didn't recover themselves because we had no therapy. So we could not heal the people. I don't know if you remember, but it were really scary period, because literally, if someone took the COVID, you had to trust in fate. I know there were no therapies. This is a summary of pre, during, and post-COVID autopsies. As you know, during the pre-COVID autopsies, it was really I don't know how to say it, but this was a really safe approach. Today, if we look at these pre-COVID autopsies, we are it's not it's an unfamiliar process because COVID gave us an important lesson from from lots of perspectives. And from our perspective, we can go past, we can look at the pre-COVID autopsy, because now with virtopsy, look at the colleague before, the virtopsy fundamentally didn't exist. The COVID improved the virtopsy, improved the minimal invasive autopsy. And now we have finally the post-COVID CBRN model, a CBRN model with the facilities with advanced filtration, with the risk appropriate PPE. For example, before we didn't have adequate PPE. When we performed the autopsy, it was a blind autopsy. Now, if there is just the possibility, you have to take the adequate control measures. Now, the graduating with new protocols, integrated approach, however, here is the problem, because I don't know if you ever thought about it, but from our point of view, the big problem during that period was only one, because the key concept was she's dead with the virus, or the death is caused by the virus. It was a really big ethical challenge, a big problem, even from a medical legal perspective. Imagine your father, your parent in a hospital which was suffering. They instantly call you and tell you he's dead. He was a COVID positive. COVID unfortunately took his life. You have to trust in him. But the real truth, you will never know the real truth, because you couldn't understand it was really dead with COVID or by the COVID. And this was really important. And the only way you can understand is with autopsy, performing an autopsy. Because if you can afford an autopsy, you can go deeper into the tissue. You could see the lungs, you could see the heart, you could see if the problem was related from a pulmonary sickness related to COVID, or was, for example, an heart failure. Because, as you know, imagine this situation. I just told you this situation. A patient dead with a positive COVID swab. So they told you he's positive. He was dead from COVID, and you trust them. But with evidence of acute myocardial infection without pulmonary involvement. So they told you he was dead from COVID. But the real truth, what was the real truth? You could understand the real truth just with an autopsy. Because with an autopsy, you could go deeper and you could see with microscope, and from a microscopic point of view, the lungs, you could see that was no pulmonary involvement, but it was, for example, an acute myocardial infection, an heart failure. This was a big problem, a big challenge. And today we are facing these liability cases. Even today, the prosecutor office called us and said, can you help us to understand which was the cause of death? You know, this from our point of view, when we took, for example, we go deeper and we go during the autopsy with the microscope, we could understand, for example, that, okay, I can understand that this is an histology, a microscopic point of view of heart. And this is a pulmonary histology showing the diffuse alveolar damage, which was typical of COVID. For example, if I perform an autopsy, I could take a sample of heart, I could take a sample of the lung, and I could see, for example, if there was a diffuse alveolar damage related to the COVID-19, or it was, for example, an heart failure. You know which was the great problem. Now I think you have the elements to understand why it was really important, for example, even from the first phase to perform autopsy, to let the science grow and understand this situation, this new situation. As you can see, these were the comparison. These were real lungs affected from COVID. Without autopsy, you couldn't understand, you couldn't see properly these pathological findings. As you can see, these findings forced the man to have a transplant, a lung transplant. Because I can assure you that because my first job, when for example, I graduated in medicine in October of 2019. As you can see, about 4 months later, there was a pandemic. So our court was the first in Italy to be immediately enabled. We were the first in Italy, I think, in history, to not perform the exam, the final exam, because there was an high request of doctors in the system. And there weren't the doctors. We weren't ready from this emergency, you know. And I can assure you, my first work, for example, was in a long-term care facility for only COVID-19 patients. I, as a first work, saw with my eyes what could do in the first phase, the COVID in the patients. I literally saw people which was considered recovered after 2 months to have respiratory failure. I saw people 3 months after the recovery, which was around 1 a.m., always around 1 or 2 a.m., they surely went through a respiratory failure because there weren't the vaccines. You know, it's easy to say from another point of view that, for example, vaccines didn't help. I can assure you that the first people who took the COVID, these were their lungs. This was the damage because literally the COVID was a new virus, which made you know, in medicine it's called the jump from a speech. So it was a bird virus, a monkey virus, and when in medicine a virus jumps from an organism to another one, it's always the same thing. So literally in humans, when this happens, the virus is highly destructive. And this was what happens to the first, unfortunately, people who were in contact with the virus. We were really lucky to, for example, in Bergamo, you know, in Bergamo, the first ones who had the first contact with the virus, it was another virus from what we went in contact, you know, because it was an adaptive, the virus is an adaptive virus, so it's different from the first one to the second one, to the first one, to the fourth ones. This other, for example, what, for example, the autopsies helped us for. Autopsies helped us to underline, finally, to understand what the COVID was the main failure, the main damage. The main damage was a pulmonary artery thrombosis, or which you can see from microscopical points of view and from microscopical points of view. If you don't perform autopsy, you will never understand that the real problem was even the microangiopathic problem, the pulmonary artery thrombosis. After the first autopsies, after this knowledge, we finally could understand that we must introduce in therapies, for example, the anticoagulants. And I can assure that this saved a lot of people, really a lot of people. This made a difference in changing, in probably challenging the COVID-19. And it makes the difference for every pathogen we don't know. It's just the first step. As you can see, these are really different from a normal lung from a microscopic point of view. A normal lung has not these. These are immunitary cells. These points. You won't find these in a normal lung. You won't find this. This is a fibrosis because COVID-19 acts like a pulmonary idiopathic fibrosis, and it was really a misunderstood problem in the first phase. You simply didn't know. Now, just to make something different to change, you know that high virulence pathogens on the human body can affect the human body from different points of view. I have just, for example, a few questions for you. For example, what do you think about it? I think it is not too impressive for you, but I think you are strong enough for this. What do you think about? Which is, according to you, the pathogen? Feel free. Just say everything. I don't. It's just an interactive lesson. I didn't understand the lesson. Which is the pathogen? What causes this? You think it's a normal death?
No.
Okay.
No. It's
What do you think is?
hemorrhagic fever.
Mm-hmm. We are near.
Ebola.
Ah, exactly. This is the Ebola. For example, when my colleagues went to Africa during the Ebola spreading, this was what they were facing up with their eyes. This is what they saw. Imagine you are a doctor and they call you because he's a dead body. So you go to see him and you find this. As you can see, the only way to understand is to perform an autopsy, to study, to collect samples from the brain, samples from the lung, samples from the heart, samples from the tissue, the skin tissue, to analyze the tissue, to understand the pathogen. Is the only way we can understand a new virus, a new challenging pathogen. As you can see, this is what usually at Ebola, after performing autopsy, we learned. There was a really literally suppression of immune response. So there was the infection, the vascular system. Literally, the Ebola destroys the vascular system from the smaller vessel to the bigger vessel. So after the destruction of the vessel, you can see the hemorrhagic fever, the coagulation. There was a disseminated intravascular coagulation, so the body is literally full of bleeding everywhere. The vessel has like, an hydraulic tube, a tube full of holes. So everywhere you have a bleeding. And if you don't perform autopsy, if you don't study the dead bodies, you simply can't understand what you're looking at. From the gastrointestinal tract, abdominal pain, from the liver, the necrosis. How can you understand? How can you see a liver necrosis if you can't see a liver? I think, a virtual autopsy can help. But do you think that with virtual autopsy or with the minimal invasive autopsy, we could understand a necrosis from the liver? If it's the first time we see it, how can we understand from a TAC, from an MRI scan? It's the only way we have, the only instrument. The same for the kidneys, the same from the systemic response, from the nervous system. We saw, for example, with Ebola, a particular tropism with the brain that led to confusion, that led to coma. In fact, in later stage, a patient with Ebola had coma. and only performing examples of brain and see, as you can see with microscope, the brain cells, you can understand what is inside it. What do you think about it? Feel free, even from outside. Just feel free to
Yes. Plus.
not. And I can show you that. Imagine they call you, you go and you see this. For example, chemical,
Biological.
biological, okay.
Anthrax.
Biological, anthrax,
Burns, maybe burn.
burns, not burns,
Chemical.
chemicals. Okay. So biological, chemicals. Other questions, other answers?
Chlorine attack.
Chlorine attack. Other supposition?
It's an explosion.
Yes. It's a chemical explosion.
Explosion.
Radiation.
They're engaged.
They're engaged.
Mr. Engage. Okay. This is a radiological attack. This is what you can see when a body is literally irradiated from tons of radiation. And this is a famous photo because it happens in Tokaimura on the 3rd of September. And it was literally a radioactive accident because the disaster was caused by the improper mixing of uranium and nitric acid inside the tank. Instead of using 3 kilograms of depleted uranium, as required by the law, the worker exceeded the limit, reaching up to 16 kilograms. So there was a chain nuclear reaction with an intense gamma radiation emission, followed by a blue flash. They reported a blue flash from this nuclear accident caused by the neutrons. And then at 10:30, there were 3 technicians, Hisashi Ouchi, Masato Shinohara, and Yutaka Yokohawa. This was, for example, this was Hisashi Ouchi. This was his body. He had 45 years old. And for let you understand, usually the IM amount compared to the safety is 50 millisieverts. He absorbed 10,000, 20,000 millisieverts. You can understand what is an irradiation.
For millisievert, doesn't do 1 hour.
From explosion. This is what happened to your body if there is a nuclear accident with a big irradiation, with a big explosion. So even, yes, there was the cutting of the feet.
That also has nitric acid.
Yeah, because it was it's a combined. Combined damage may be radioactive, but it was a partly explosive. When you have an explosion, there is also the traumatic damage of the explosion with the gas, and the gas can be very destructive for the other parts of the body, for the hands, from the feet. So you can see it literally was without skin, I don't know, was literally irradiated. And this, you have to imagine, for example, is what you have to face, for example, in the big nuclear accident. Imagine now, for example, after the atomic bomb, after the big nuclear accident in history. You can put these photos in books, but this was what you were, you could look if you go if you go there.
Why is that position?
And this was because he stayed recovery, he absorbed this and he survived for 35 days.
Really? So,
Yeah.
so he survived 35 days.
He survived, they tried to recover him about 2 or 3 weeks. Imagine what was the agony, what was the damage, what the suffer from the, they tried to save him, but unfortunately the damage was low. Over the 90% of the body. It's like it was impossible. It was impossible to recover him. What do you think about it?
Anthrax.
Easy.
Yeah.
It was easy for you. It was the anthrax, right? As you can see, the anthrax effects on the human body is that even with the autopsy, performing the autopsy, we could take a skin sample, for example, and to understand that the cutaneous anthrax is the leader, the first phase. This phase, the anthrax spread in your skin. Then,
She's alive.
yeah, she's alive. The first phase, you have the skin problem. After the skin problem, or with inhalation, there is a different clinical presentation. For example, with inhalation, you have directly the inhalation of the spores into your lungs. So you have a systemic spreading of the pathogen. It's a different kind, as you think, for example, when you have flu-like symptoms in anthrax, it means that the pathogen is spreading. It's through your lungs. So you have the first respiratory distress, the chest pain, the shock, the toxin that causes hemorrhagic mediastinitis, and I can show that you can see that. You can see all of this. If, for example, you perform an autopsy on a patient with anthrax, when you open the chest, you literally find just one block. It's like the thorax, the lungs, the heart are collapsed. It's like it's like a fusion.
Yeah.
It's all the same tissue. And I can show that a patient with anthrax is really even difficult to, with advanced anthrax, to open the chest because it's difficult to go deeper because of this fusion of tissues. It's not so easy to, for example, to isolate the heart. To isolate the heart, you have to pass through the lungs. To take away the lungs from the chest, you have to first cut these tissue bridges. And when these tissue bridges are from anthrax, I can assure you it's really hard to even to manage the autopsy because it's really hard to understand what are you doing. It's just I don't know, to a complex clinical picture. Even from our point of view, the tissues are really different to cut, to isolate, and even the microscopical sample, it's hard to take a microscopical sample. At latest, this even the inaction anthrax, and this was related to, for example, toxic abuse. In toxic abuse, even you can have, for example, the inaction anthrax by the spreading of, because anthrax is a spore. It can be in ground to the ground. If there is a transmission of drugs, of materials, the heroin or something else, you can allow the spores to come in contact with your blood. So it's a direct infection, and in that case, you can see the most lethal clinical presentation. In fact, but this is even for other pathogens. It's not different from other pathogens. So once in the bloodstream, the anthrax toxin can cause septicemia, shock, multiple organ failure, and death. Obviously, when there is a spreading, the final spreading, it's really hard to recover to recover the patient. It's really difficult, almost impossible. Just I find an interactive case just to let you go away. I hope it wasn't a boring lesson. Just I want to perform an interactive lesson just for you. And imagine a body found in a clinic, so in an hospital, in a COVID red zone during the COVID period, with no swab performed. So you don't know if it's positive or not positive. We just find him in a COVID red zone. He's an healthcare worker, but there is also a complaint for clinical error. So you don't know, no swab, but you, what should I do? Would you perform an autopsy? What setting issue would you adopt? And what legal and health risk you can consider? I think after the lesson, you can easily answer to this question, but I just want to listen to your opinions. Would you perform an autopsy? Would you can you come in contact? What do you think? You have no swab. You don't know if it's positive or not.
Perform an autopsy, but with the PPE.
Okay. With proper PPE, yes, obviously conditionally. You have to perform an autopsy because, as I said before, you have to clarify the cause of death. Don't forget that even if he's dangerous, even if he's in a COVID danger zone, you don't know which is the cause of death. You don't know, maybe he can be your father, your son, your sister. I think it's your interest to understand the cause of death. It's your primary desire to understand why he was dead. And even from the legal implication, if you don't perform an autopsy, if you don't study the documents, if you don't study the clinical ether of the patient, you can't understand which was the cause and the manner of death, even from the absence of the diagnostic swab. Because, as you can see, the autopsy is the only way to confirm if he's a COVID-19 patient and identify alternative causes. It's the only way. But I think that for you, it can be even it's easy to say this. But trust me, for example, in the first phase of COVID, it was no, in this case, okay, that maybe a positive swab, okay, he was dead from COVID. The death was caused by COVID. As I told you, the situation is difficult and is surely more complex. Even from a public health surveillance, you know, if it's a pathogen, if it's another virus, if it's a public health problem, you have to understand this. Because it was an healthcare worker. If he's an healthcare worker, you can assume that he was in contact with other co-workers, with other patients. So in a cDNA events, you must consider this. You must consider that the hospital is the first facility where you can find, for example, the spreading of a new pathogen, a new misnown, underknown pathogen. The safety measure, our friend told us, the PPA, the procedure, I told you the procedures. And even from a forensic point of view, from my point of view, however, you know, is the only way to know if there is, for example, a malpractice. The fact that it was positive or not positive from COVID, it doesn't mean that there is, for example, malpractice. For example, an error during the surgery, an error during the therapy. You can't understand this. Maybe it was an heart failure and they didn't give him the right therapy. And it's the only way, even to certificate the cause of death for insurance. For example, if you have insurance, if you have a personal insurance, the insurance can give money to your family only with certain conditions. If you don't have this condition, for example, the family without a father, the family without a mother can't afford the money, for example, from an insurance point of view. And even from a biological hazard, because from our point of view, it's a way even to understand the lack of the system, the problem in the system, to improve, for example, the procedures or the occupational risk. So I hope this was one of the first period my teacher in my forensic pathology school told me the autopsy is the patient's final voice in time of crisis. It is also the biological memory of the truth. You know, I think now you can understand why it's the only way to understand and to have a biological memory of the truth. I really thank you. If you have got any questions, feel free. Adesso mi rompe. Ok. Vediamo domani.
Vediamo, ciao.
Ciao.